Good afternoon, and you're welcome to this edition of QPS TalkTime. Today we're coming from the Department of Health at Messian Place on Baggot Street in Dublin, where there's a workshop on the implementation of the HSE's patient safety strategy. And there are some guests attending here from the International Society for Quality in Healthcare, ISQua, and we have the opportunity to spend some time talking to them today.
So what are we going to talk about today? I think kind of some of the things that we've been talking about this morning at the workshop here, we're going to try and gain some insights into the international perspectives from our partners in ISQua on the implementation of the HSE's patient safety strategy. We're going to discuss a big theme this morning was learning health systems in Irish healthcare, and we're going to discuss that. And then we're going to discuss about how health and safety is addressed in other countries, and we're going to have a chance to have a conversation with Dr. Ezequiel Garcia Elorrio, who's the president-elect of ISQua, about the experience of safety in Latin America. So I'm going to start off by welcoming Orla. Orla, you're the National Clinical Director for Quality and Patient Safety and the National Quality and Patient Safety Directorate. Would you just tell us a little bit about the HSE strategy for patient safety and where we are with that at the moment?
Okay, thanks very much, John, and thank you to all of my colleagues, international and local, for joining us. I think most of you are quite familiar with the strategy, but and our focus is going to be to listen to the international experts. But just a very brief recap. That strategy, a 5-year strategy, launched in 2019. The vision for which is that all patients and service users who use our health and social care services will consistently receive the safest care possible. And we have made 6 commitments within the strategy to that end. The first being to actively empower and engage patients to improve safety. Secondly, to empower staff. Thirdly, to anticipate and respond to the risks to patient safety. Fourthly, to reduce the common causes of harm. Fifthly, to measure and learn to improve patient safety. And finally, to provide effective leadership and governance to improve patient safety. Why is this important? Well, it's important because we know, as John, you pointed out to me very early on in this job, we're still not safe. And up to 1 in 8 people who access our services will experience a harm, and that's anywhere between 50 and 70% of the harm experienced is potentially preventable. So we have the commitment of the board of the HSE, the executive, and our colleagues in the Department of Health to implement this strategy, notwithstanding the interruption of the pandemic, but then the entire world was interrupted by the pandemic. The last 2 years has seen us redouble our efforts at implementation. And I think today marks a really important milestone in the collaboration between ourselves, our patient partners, and international collaborators in driving that strategy forward. The other thing that's happening locally that affords us a huge opportunity for patient safety is slow onto care and the implementation of RHAs. And I know change is continuous, and change can be exhausting for people, but change brings an opportunity, and the RHAs bring an opportunity to again redouble our efforts to implement the strategy and to ensure that whatever service we put in place and whatever configuration we arrive at supports high quality, safe patient care.
Or this morning, the workshop this morning, and why we're all here today is to talk about implementation. And there was lots of ideas this morning that people were talking about. What were the important ideas from what you heard this morning that people were raising, and ideas that we need to use to implement the strategy?
John, you weren't supposed to ask me the hard questions. That was for the panel. But there were plenty of ideas, and it was quite clear that a lot of the component parts are in place already from the work that we're doing as part of strategy implementation, and that includes, I mean, our focus clearly was on a learning health system, and how we learn and how we share, and would reference the Patient Safety Together platform in that regard as some of the work we're doing. Patient involvement, listening to the voice of the patient, was to the fore, and we were very well represented today by patient representatives, and that's something that we've embedded in our strategy, and is embedded in the implementation element of it. Data, the use of data and information to inform, evaluate, and learn. And I think they were the three big things that struck me from this morning, but I'm sure my colleagues will have more to
Yeah,
add.
and I think we'll ask all our panel the hard questions as to how we do it. I think, and I was struck again by the presence of our patient partners there today. Several people. They talk a lot about culture and the importance of culture.
Huge emphasis on culture, and our international colleagues referenced the patient safety culture in their systems vis-a-vis ours, ranging from blame culture and no blame culture to the just culture that we're striving to demonstrate, to achieve and demonstrate here in Ireland, and that patient safety culture was at the centre of threaded through the entire discussion. In fact,
and the other thing that struck me this morning was how good people, I think, felt to be back together, talking in a room, and the breadth of experience here from across the country in terms of all the disciplines and the importance of getting people together to
yes, I think that's true. There was a feel good factor in the room, at the risk of some toxic positivity here. There definitely was that feel good factor at being together and sharing our own experiences and hearing other people's experiences and celebrating success.
Yeah.
Celebrating success and not consistently focusing on the negative. There are a lot of good things going on. We have a good strategy. A lot of the elements are in place, and it's about capitalizing on that now.
Yeah, I think that was acknowledged, wasn't it, by our international guests this morning and partners, and how the strategy is good, and it's just about getting the key bits of it and implementing it.
Exactly.
Super. Thanks, Orla. Jeffrey.
John.
It is lovely to see you again.
You too.
Jeffrey, you were talking this morning. What were you talking about this morning?
So I was thinking a lot about the Irish health system. ISQua, which I'm the president of at the moment, is domiciled here in Dublin, and proudly. It was in Australia for a while, but it came to Dublin and came to Ireland for a few reasons. But one of them is the Irish health system is really good in parts, but also it's a work in progress. And it's a fantastic example internationally. So a lot of our work is international. We work in low, middle income and high income countries. Being here, though, gives us some insights into the Irish health system and some of its strengths. What we were talking about today, and I gave it an address, was on the Irish health system as a learning system, with an emphasis on some of the things all can say, but with an emphasis on learning and continuous improvement. So just step back for a second. It's a learning health system, because in a way it's just a few words strung together. It's just a bit of jargon. So the Institute of Medicine in the US and several other people have taken this idea and run with it internationally. And it's the idea that you put together the data that you have available from all different sources. We know that's something sometimes hard to put together and aggregate. To put that data on a regular, continuous basis in the hands of decision makers. I don't just mean clinicians on the front lines. I mean patients also, having access to data by which they can produce care, make a good decision. Policy makers too. It also says, how do we get the informatics in place and the knowledge about what is good care, the science in PubMed, in studies in PubMed, into the hands of people at the right time? How do we create the incentives for continuous improvement? And how, as Orla says, do we get that culture of continuous improvement, even if we're facing headwinds and challenges such as there are enough resources, there's always difficulties in using current IT systems, all those sort of basket of things that make it challenging to deliver good care. So as a galvanizing concept, this notion that can the Irish health system be at the micro, meso, and macro levels more approximating the ideal characteristics of a learning health system, that would be really useful. The planks are in place, I think, in Ireland. You have a really good, well-articulated patient-centered strategy.
Yeah.
The HSC has delivered very useful documentation and policy. And I know there's an act currently on the table in Parliament to create the structure and the regulatory and policy framework within which the system can respond. But it's the front lines where what really matters takes place.
Yeah.
So what do people on the front line need in terms of tools, evidence, data, and what patients need and what matters to them? I think that brings it together.
Yeah. We had Tom Foley, who I know you know, on with us a few weeks ago, who's a leading academic in learning health systems. And one of the things Tom talked about was the importance of learning communities as a kind of bedrock of creating learning health systems.
Yeah. So Tom's a good friend of mine. We're on a group together with a bunch of people in Washington, D.C. and in Europe and the States, looking at how do we apply the learning health system knowledge that's sprouting up everywhere. So learning communities, we've done some work using, those network diagrams where people, the dots are people, and they're connected together or not connected together, as the case may be. And it's illustrative of how collaborative teams that are providing the care, or say a whole hospital, or even an RHA, how are people connected across an RHA to deliver better care? So we do a lot of that sort of work. I can send people studies if they want to send me a text or an email. And this is an idea of across time, how do we connect up patients, policymakers, patients and patients groups, leaders and managers, and then people like me, researchers, to improve and sharpen the care that's delivered on the front lines. And that's Tom's idea of a learning community in practice.
And allowing, I suppose, these communities then, when they do learn, to be able to share in that networked relationship and trying to facilitate that. And I suppose, how do we create the conditions to allow these learning health systems come about? And what are the most important things, or where should we start?
So my sense is, what do those conditions exist in Ireland at the moment?
Yeah.
How do we liberate them? It's perhaps even a more interesting question. Not that your question wasn't good, John. So we know people are tired. They've come off the pandemic. They've gotten together, and you're right. Orla, it was engaging this morning to see people being engaged. It was very encouraging to see the way people interacted across this workshop. So the conditions are there. I think helping people with data, giving people a license to collaborate effectively, and done a lot of work on culture. Ezequiel will talk about that shortly, I'm sure. If you can engineer or have good culture, one that's relatively non-toxic, we've all worked in toxic cultures where it's disabling everybody. If you can have a better culture or be on a pathway to better culture, you've got more chance of building a learning community, everyone benefits. I do wonder how come healthcare produces sometimes toxic cultures when all the people in that culture want to do good things for their patients.
Yeah.
How does that happen?
And if the likes of Amy Edmondson, who talks about this concept of teaming, where culture emerges from learning together and doing things together. Do you think we can we can do both. We can create a culture of safety and learn at the same time.
Well, there are examples here in Ireland already where people are doing that. The
Yeah.
question is, how can we spread that?
Yeah.
How can we learn almost from each other? And the best places are already productive and relatively built on good relationships. There's no nirvana. There's no perfect place, and we should stop looking for the perfect place. That's only in textbooks. But are people relatively good in some teams, and can we learn from those teams about how they do it? That's gold. That's where the gold is.
And joining up, the patient safety strategy has 6 commitments involved. One of the big commitments is around addressing the common causes of harm. Do you think we can get to a learning system by building it in pieces and then connecting it together and working on it, or does it have to be connected from the start?
No, I think it's always a journey. I think we're, in a way, what we're trying to do is we've started with a plane from the past, and we're trying to build an A380 while we're in flight. I think that's what we're trying to do with our system. It's even more complex than that. So while we're flying the plane, we've got to rebuild it into an A380. So that commitment's very important. I would say just that, though, that safety 1 and safety 2.
But you just safety 1 and safety 2, because I'd really like to hear your explanation of those 2 concepts.
So safety 1 is how do we reduce 1 in 8? Did you say? And 70% is preventable.
50%.
We should not stop doing that. That's safety 1. That is, how do we reduce harm? Some people have said, how do we get it to 0? Skeptical. The system is complex. We're going to get it to 0, but how do we get it down? How do we get harm reduced? So we've been working on that for a long time. Safety 2 is really the other side of the coin. Is if harm occurs in 10 or 15% of cases of admissions, and we've focused on that for a while, then the question is, what about the other 85%? How come? The very powerful question is, how come care goes right so often? Now, even when I say those words, you sort of think it's a bit strange, but it's true. Most care gets delivered well, effective clinical teams to patients who are grateful for the care they receive. So the question is, how do we do more of that? That's safety 2.
Yeah.
So I think we've got to walk and chew gum. We've got to do safety 1 and safety 2.
Yeah, it's not one or the other, it's both.
No.
And how do you think, learning health systems, safety 2 is complex, isn't it? And part of it is about embracing complexity. How do we use learning systems to learn about complexity?
One of the things we do is we do intensive studies about who's in the network. It's connected centrally in the network and is actually the glue that makes it work. Who's the knowledge broker, if you like, or the knowledge holder, or the opinion. And then who's an isolate, not so connected into the complex adaptive system. If we bring them in, firstly, we've got more resources available, but secondly, we've got that bigger team that you started off with in your question.
Yeah.
How do we build that and connect it? That's really a major game. And when we go to Ezequiel, he's going to talk a bit more about culture.
And one of the big themes I think that came up this morning is time. Is finding the time to do this. Does it need to be separate time? Any thoughts on that?
I've got two thoughts. One is time in the sense that you do need time out sometimes to think, reflect, the reflexive. How do you get that? Well, some people manage to do that regardless of the resources available to them. They create that space. Other people think, I've got to go to a conference, get away from it all, maybe make a presentation at a conference, or just sit and listen to some other people. And then in the breaks, interact with them. People from different health systems from another system. It's usually enabling of people, inspiring, a bit encouraging. The third thing is we do research on this. We have a tool called observation measurement by activity timing. I'm from Australia, okay? We had to figure out a lot about how to get that acronym. And it actually measures clinical time. One of the things we've noticed, it's in 16 countries, many studies. One of the things we've noticed is people spend a lot of time doing things that aren't that productive. If we can reduce that, we've released a bit of reflective time or patient care time back to the system. That's my plan.
As president of ISQua, you've got to travel the world maybe and see different health systems. And what do you think is the most common thing that people have done to really get on this journey?
I think it comes down to something, in fact, that you said this morning. It's about national culture as well as the culture of teams. And you pointed this to us when you did your introductory remarks. It's what the characteristics of the national culture. So I claimed I'm 12% Irish.
And we welcome that 12% wholeheartedly different.
Because I did the DNA sequencing thing. 12%. And one of the things I know from coming to Ireland quite frequently and maybe being 12% Irish is there's this optimistic pessimism. Okay? The optimistic bit in Ireland is fantastic. Pessimism is not bad either because it allows one to be a bit skeptical and challenge the status quo. I think you need both. I think Ireland has that in great measure. And I would trade on that natural national characteristic of wanting to do well, but being a bit skeptical at the same time. I think you should treasure that.
Jeffrey, last question. You are a researcher. Is research important on a national basis?
What am I going to say, John?
Well, I want to hear that.
Of course. There's 35 million papers in PubMed. One of my jobs would be to help people knowing a bit more than the average person what's in that literature to try and translate that for the benefit of people with delivery care.
How important is it that researchers work with us, I think, in creating the learning health systems?
In my research institute, I've got 300 people associated with a big health service that we don't splice genes or we don't have a wet lab. We do health systems research. We've got 129 projects going on. Every single one of them is with a partner in that system. You can't do this sort of research, quality and safety, improvement studies, without doing it with people and patient groups, not on people or at people.
So, Jeffrey, pleasure. Thank you very much.
Thanks, John. It's a pleasure catching up with you again, John.
Thank you.
Thank you very much, John. It is an absolute pleasure to welcome Dr. Ezequiel Garcia Elorrio, and I hope I pronounced that properly. You can tell me if I didn't, who is the president-elect of ISQua today. And this morning you were talking about creating a culture of patient safety in health systems. I'm wondering, could you tell us just a little bit about that for the participants of today's talk time who didn't have the option to be there this morning, maybe?
Thanks a lot for the invitation and to share this time with you. I would say that what I learned about culture and trying to define it in a very simple way is that the way we do things. And culture, it's part of a country or a society. And I came from a society that is not very respectful of rules. And sometimes we don't follow the appropriate rules of the right behavior to do better for ourselves or for others. So what I try to share today is that culture is a critical piece to achieve zero harm. As Orla mentioned, Dr. Healy mentioned about the importance, and it's critical for me to learn from the Minister of Health about the recognition about care not being safe. It's a very important piece of information to share with the public. I believe that it's critical, again, that we try to understand which are the levers to make care safer. And culture, again, the way we do things, needs to evolve to make care safer. And we need to learn from other industries that for different reasons became safer at the level of zero harm almost, like the aviation industry. And here, a much more complex industry like healthcare, we need to develop an ecosystem that helps providers to be transparent, to open themselves, to learn from their mistakes, and not to be, they need, of course, to be accountable, but again, they don't need to be punished excessively for mistakes that are systemic mistakes, not personal mistakes. So from there, that openness leads for us to be more transparent, to share data, as Dr. Braithwaite said, to have learning attitude, a learning curiosity, to have more understanding in the way we can prevent these mistakes to happen. And also this culture, again, whenever we're referring to society, has to align with the cultural values of society and also the judicial system. Because again, countries that have understood that punishment does not prevent medical adverse events to happen, we need to learn from them, are countries that are making progress in creating this culture for patient safety that is what will make us get to the next level of safety in a very complex and changing environment. Hopefully that summarized what I shared today.
It does really well, and there's a lot in that. I think one of the things that I was struck by this morning was you talked about systems can be different in different parts of the world. You know, and the culture is obviously quite different, but that there are still key learnings that can come from different areas that are universal. And we might chat about that in a minute, but I'm wondering, you know, would you like to share some maybe examples that you might have come across in your work of quality improvement work that was done really well?
Good. You know, a reflection that I have is that problems are not that different around the world. It's something that we always need to keep in mind. Of course, solutions may differ, of course, of context and resources, but problems are the same. And I would say that I feel along my career and the group that I'm part of is that I'm enemy of waste. And waste, it's the greatest enemy of health systems in general, particularly in my region of the world. You know, our region of the world is neglected by foreign aid sometimes because we have somehow enough resources. Of course, we expend the same as Ireland in the GDP percentage. Of course, we have different GDPs per inhabitant, but we expend 10% of our resources in healthcare. And the level of waste is huge. It's about 30-40% estimated by the funders of healthcare in my country. So that waste prevents vulnerable populations to access the care they need. It creates an environment where payment models and incentives are related to usage and not to prevent adverse events or to prevent or to give people the care they need. So what we tried to do in the past is to collaborate in applying evidence into practice. Because even for countries that do very well, like yours, of course, that's an opinion from the outside, there's always a chance to improve and to do better. And again, research, and I can define research as light. It's the light that shines on our performance and that helps us to choose the right interventions to improve care. So what we have done in the past is to try to identify gaps in care, try to identify interventions, and using a very technical word with a technical strategy was called implementation science, to identify the way in which evidence is applied to practice. My sense is that your health system has already started different ways of trying to promote better performance by identifying the right interventions to be applied in the right settings.
Yes.
So, and of course, we have worked in a number of interventions, and you know, the biggest problem still in our region of the world are hospital-acquired infections, which is not such a big problem in Europe and the US, but unfortunately, in our region, it's a very important problem, and it's emphasized by the wrong use of antibiotics, for example, and antimicrobial resistance have produced even more severe infections in our region that could be prevented.
It's quite significant. I'm struck by what you talked about waste. You know, a few years ago we did something with a hospital in Kerry, and they asked a very simple question: what portion size do people want with their meals? And it was something really, really simple, but it was really effective from a waste perspective.
Our portion of the meals that we're wasting are readmissions, infections, well, preventable deaths, lots of things that could be different.
Yeah, I'm conscious that you touched on that idea of the universal solutions. Are there other universal lessons that you've come across in that space? One of the things that you touched on, I think, this morning was the benefit of, from a cultural perspective, you know, leaders being in the field and being visible to staff. And I thought that was really interesting from a broad perspective. I think that's something that would apply here as well as in other areas.
Absolutely. I would say that the biggest lesson is that we need to design health systems with people, for people. So I would say that's a general lesson that all health systems around the world may hopefully understand. And hopefully, not sure yet, the pandemic has taught us a lesson on how better design health systems reacted better to the pandemic and potential threats that may occur as a pandemic or as a silent pandemic, like the pandemic of obesity, chronic conditions, mental health conditions, things that happen all the time and still happen affecting people around the world, and we're not addressing very well. So the right design is important, data transparency is important, the right leadership in terms of recognizing as you're doing the things that could be better, and also using the right evidence in the right setting.
Okay. It's interesting in our conversation and preparing for today, we talked about the work and how beautifully easy it is, or the actual opposite of that. Why is it so hard? And it's something that you touched on a little bit. Why do you think it is so hard? Why do you think this quality and patient safety work can be so hard within systems?
Well, because first it's very difficult. The addressing a zero harm goal, I would say it's aspirational by different reasons. Then, because the system is very complex, it's made of people, and people interact in different ways, and it's a moving target because one thing is to achieve zero harm in aviation, on aerospace and space travel, but addressing biology is much more variable and difficult. So I would say that, again, the case of understanding complexity is a recognition that we need to address in order to improve. So again, it's a moving target. The context affects decisions a lot, the economy, conflicts, different migration. So as I said today, so again, for me, the most important thing is to recognize that it's a goal, important goal for health systems to address, to improve care, to reduce the harm, and also reduce the economic impact of safety, of unsafe care. Because it's something that, especially for countries like mine and others, this burden of the economic impact of safe care it's preventing others to get the right care they need.
If you were thinking of the people that are watching this today, with people from across the country here in Ireland, with people joining us from Saudi Arabia and Turkey, there's so many different.
Please don't tell me.
Yeah. So if you're thinking of that, and they're all in different roles, what would your advice be to them if they're starting off quality improvement, or if they're in the middle of it and they're looking at this and saying culture is key to patient safety? What would your advice be for them on getting into that and making it work?
Well, there's no simple advice, but at first I would say that, as we told today, the tendency is to engage with locally with providers and citizens, patients, and also to engage with peers, because again, problems are similar, solutions might be used, and you can do it through PubMed, getting the best evidence, but also you can do it with peers in networks of collaboration. So I believe that there's a big chance to contribute. Also, we have world-class regulators like WHO, societies like ISQua, different stakeholders working in different sides of the world. So I would say that there's a lot to learn from others that could be applicable to every setting, and that's a good start.
It's really helpful.
We shouldn't bend the wheel because it's been invented already.
No, that's really
Yeah.
true. I think one of the final pieces, and we'll stop then. But the final question I have for you, you touched on it this morning about the importance of teamwork. Could you tell us just one or two things on that?
No, I just mentioned that that the interaction between people, or between providers, the public, and between providers themselves is critical to build a culture. So I feel that it's amazing that health providers deliver so complex care in a way that could be so much better in the way we interact with other providers. We always respect pilots, military, or other complex professionals, high-risk professions, and healthcare is very complex and high risk, and we should do better in the way we deliver care. And I believe that teamwork should be a part of every curriculum for every health professionals to learn during their careers and sustain that along their work.
Yeah, it's interesting. We came across this paper a few years ago. Michael West was involved in it, and they talked about teamwork, and in particular the impact on patient mortality. And they said that if you have real teams working together, you can reduce patient mortality by 3.3%. So you're looking at about 40 deaths in an average hospital. So it's quite significant.
It is. I would say that, from my perspective, the evidence is not that striking, but may vary across settings. But it's so clear that we need to do better in the way we interact with each other, how we communicate, and we should stop admiring others and apply those learnings to our setting, to our professions. It's something that hopefully we can do because there's no more time. We need to really move faster. Maybe Dr. Brown didn't mention it yet, but we just attended the Montreux summit from governments all over the world, just trying to improve safety. And the general director of WHO said that it's not care if it's not safe. It's a very good summary of how care should be.
It's not care if it's not safe. Yes.
I hopefully did it well. I said it well, but
You did. No, thank you so much. Thank you very much for that. So that's been fantastic. We're going to now talk to Rachel Kenna, who's the Chief Nursing Officer within the Department of Health. And thank you very much for joining us today. So one of the things that I suppose that was talked about this morning was the patient safety strategy and improvement in action. From your perspective, obviously the Department of Health is very involved in all of this from a policy and a legislative perspective. But if we were looking at how important do you think quality and patient safety is as an enabler of quality care?
That's a great question, and I think probably reflecting on this morning, as somebody who's 100% Irish, having our international colleagues with us has really given us some food for thought in this area. So I think it has been a great reminder to me in the policy space that quality and patient safety are inextricably linked, and there's no doubt about that, but that there is a lot of moving parts with both of them. And if you take the basic definition of safety as reducing harm, and quality is achieving the best outcomes. What I've learned this morning and the importance of it in that quality system is that you can't achieve a quality system without actually developing a learning system and a learning system. So that's really interesting to me from the policy space in trying to how you bring all of those moving parts together. It's not enough just to share information and knowledge that we need to actually go into that action space. And I mean, you heard my colleague, Dr. Orla Healy there saying that there's lots going on in that interaction space and action space, but the spaces where we can actually work on that in terms of quality system is more collaboration. And we've heard that really strong message this morning, which has been fantastic. And a really important part of that collaboration is the clinical and patient partnerships.
Absolutely. I think the patient partnership piece comes up so strongly in everything. And Ezequiel talked about that a little bit as well. In terms of the department's role around the policy and legislation that underpins healthcare delivery, I suppose from my perspective, I'm curious about how do you support quality and patient safety in practice through that policy? And I know that there's a lot of developments happening at the moment. You might like to share a few of those with us.
Yeah, no, thank you for the opportunity, because we're in a really good place with some of this work, and it's quite an exciting time because of the system that we're working in. So first of all, our fundamental principle is to make the system as good as it possibly can be for patients and staff to have the best experience. So from the policy and legislation perspective, I suppose it's really exciting. Ireland has its first ever patient safety bill going through the houses we're at the last step. We've one more step to go, but we are nearly there. So that is quite exciting. And this bill provides for really important pillars of patient safety and quality care. The main one being that it provides for mandatory open disclosure and for patients and their families when something serious does happen. It also includes other really important provisions such as protections for clinical audit and other kind of areas like that be really important. It supports a safe space for staff to be open and honest with patients in terms of reporting and engaging with them. So in addition to that then, and I am conscious of the time, but in addition to that, really importantly, we are finalising a national open disclosure framework. And this will put the unified and consistent approach then to open disclosure for all of our staff working in the system and kind of leans into the legislation piece of it. Some other really important pieces of work from the policy perspective is that we do have a national patient advocacy service. Yes. And this is really important because it allows the patients to come into the patient safety space with us and provides a partnership for them to engage with the incident management frameworks and systems. And as we've heard so much of this morning, that's really important in terms of developing that learning system. So what happened, and how can we do better? All of that comes from patients being much much more engaged with what we do. One of the other areas that we do from the department's perspective is that we have the NHQRS reporting. And I'm reflecting on that now because we have 43 indicators of quality across 5 domains. And I'm listening to my colleagues this morning and saying, if we're really going to focus on what's important, there's 3 things that are important. Okay, so a little bit of reflection, but notwithstanding the fact that it is a really important indicator and data, going back to that having that data for us to be able to work from, and information for staff on the front line to be able to relate to. That is something that we do. And I think I'll probably leave it at that. There's lots more to say, and I'm looking forward to kind of developing on some of that and helping us to do our thinking this afternoon as we go into that.
Perfect. Thank you. And just on that, because obviously the whole purpose of this is to share a little bit about what's happening with you today. Could you tell us a little bit what's coming up in the afternoon?
Yeah, I'm absolutely delighted to. And as you can probably hear, I'm still very energized from this morning. So yeah, a hard act to follow. But this afternoon, we're going to do a little bit more focusing on that patient engagement piece for a safer system, which is a really, really important piece of work. So I'm really keen to get back and see what that's about. We're going to delve more into that culture and that team aspect of patient safety as well. But really importantly for Ireland and where we're at on the cusp of massive reform in terms of that shift left and moving care into the community, we're going to actually focus on safety in the community and hear from one of our GP colleagues as well, which again is something that I think the whole room is embracing themselves to hear, because it's so relevant to where we are today. We often think of the hospital and hospital care when we talk about patient safety, particularly in Ireland, and actually most of our care, if we get it right and launch care happens, is going to be delivered in the community. So it's going to be really, really kind of enlightening for all of us to take part in that this afternoon. I can't wait.
That's fantastic. Thank you so much. And for anybody that's interested, the GP speaking this afternoon is Dr. John Brennan. And our last week's QPS Talk Time was actually with John and a number of staff within community settings, looking at the whole area of quality within the community and the importance of it and how do you actually make it happen, because it may not be as straightforward as some of the acute settings where everyone's in maybe one location. So I'm going to pass back over to John because we have an opportunity now to ask questions of our panel. So if you have some questions, you can pop them into the chat box and we'd love to hear them. Thank you.
Thanks, Juanita. And we've lots of engagement in the chat there, and people joining us from all over the country, and people saying how important the safety strategy is to their work. People from Amric, our infection control, saying that it underpins a lot of the work that they're trying to do in reducing the cause of harm. And so I think, a recognition of the benefit that having a strategy is already bringing. I have one question here, and I think I'd be interested to see panel's thoughts on it. It's about learning from when things go wrong and trying to do good investigations while at the same time mindful of relationships and trying to learn as you investigate things that go wrong, and most of that learning has to be done internally, by ourselves and our colleagues. And how do we get more from those kind of reviews? How do we learn? I had an interesting episode the other day. I was involved in a mistake at work. Thankfully, nothing bad was the outcome of it. But when I spoke to my colleagues about them, a lot of them felt it wasn't a mistake, and that was the first barrier to get past. How do we open that culture where we can, even the value of viewing things as a mistake? Jeffrey?
I mean, people have done a lot of work, including here, on a just culture to engender sufficient trust in the system so people can report. We're in a room, the incident management framework banner says care, compassion, trust. If we can get into those places where that's not a natural place to be, where there's a bit of mistrust or people are worried, and turn that around a little bit, I think we get to a better place. Can I say something else about that? It comes back to that safety 1, safety 2 question you asked earlier. So yes, if something goes wrong, we need to be able to be admitting of that and maybe participate actively in an RCA. We need to be able to say we're going to operate a just culture and not blame somebody, but we have a set of systems. But we also need to ask, how come this went right so often before the incident occurred? What were the characteristics that made us have safe care all the way up to this incident occurring? My analogy to that, John, is, if I was a researcher, marriage, and I wanted to know what a happy marriage was, if I just investigated divorce, I wouldn't really understand what a happy marriage is. So if we just do RCAs, only ask, how this problem occurred, how can it never be made to never occur again? We won't really understand the whole behavior of what makes good care. So we should ask both questions simultaneously. That can also engender more trust.
But is that difficult? Asking people to hold those two ideas simultaneously. That it's about, it's about both things, and I think it's a real challenge really to get people. We need to have lots of conversation, I think, to open up that space of learning from what goes right.
Yeah, we do.
It's not intuitive necessarily.
No, it's a journey, isn't it? It's not a destination. I think some places have done it. Some people have made more ground in their journey and said, we need to ask two questions simultaneously. If I talk to clinicians like you, John, and say, I've noticed your talk goes right. In fact, most of it goes right. Could I work with you as a researcher, John, so we could do this?
Yeah.
You will respond, just like you did. If I say, stuff it up a bit, I don't even hear this. Is it a couple of years? Let's have a look at those and see if we can stamp them out. You will react differently.
And we are opening up, I think, having conversations about why things go right. Why was it so busy yesterday, yet nobody was hurt, or we got through everything that needed to be done in a good way. And I think that is something that has, I think, gained from the ideas of safety too. Or any thoughts on getting more from local reviews and appreciating all of the pressures they put on teams and
Absolutely. And I think the first point is that we call them reviews and not investigations, and that we as nationally, we work very hard so that system accountability and a learning culture is not conflated with individual accountability, and our just culture work speaks to that. And in implementing that just culture, we've worked with a multiplicity of organisations within the service, our own HR, our own board, and organisations like the coroners, for instance, so that the reviews we conduct are used for everybody's benefit, and for the purposes that was originally intended. Working with people locally, I think we have a role to standardise the approach to how those reviews are conducted, to provide the relevant expertise when that's required, external or otherwise, to provide a QA and a support to people who are conducting those reviews, and most importantly, to learn from those reviews. And our Patient Safety Together platform provides one such platform, but it's not the only one. It's the new electronic platform, but we have now started to hold learning events following major reviews. For instance, our National Independent Review Panel reviews that are conducted in social care, and we hold a learning event after each of those reviews is completed.
And like Jeffrey said, it's a journey. I mean, I think we learn to learn, don't we? I mean, we get better at learning the more we do it.
There's another question just coming up here, and it's about simulation and patient safety, reenacting what happened to pinpoint, what went wrong. Is that something that you've come across?
Well, not in the region, unfortunately, a lot, but I would say that simulation has playing a big role in patient safety, to learn how to do things right from the beginning, and also to understand what went wrong whenever we were trying to understand what were the causes of adverse event. So simulation, it's now part of training for all health professionals. And I would say that you will find, particularly in the US, that training simulation centers are being called training patient safety simulation centers, because they're trying to harness on the importance of preventing adverse events by learning doing things the right way. So I would say that it's all new somehow for patient safety in terms of, at least for the developed world.
Yeah, I wonder if we focused on focusing on the idea of positive deviance and focusing on the good things, simulating doing it right and writing that up so that that's what we
No,
follow.
absolutely. And also simulation also, it has been very widespread for technical abilities, but what we need to learn more is about soft skills, communication, debriefing. So those are the things that eventually will get us to understand what we can do better, what we're doing well, and what we can do better.
And there is actually a question here on debriefing as well, that somebody sort of mentioned that it's difficult to get buy-in for briefing and debriefing, and it's in particular in clinical settings, and it might be seen as a waste of time. Have you any suggestions on how to maybe change the mindset around that?
Well, it's amazing that happens because the power of briefing and debriefing, it's huge. So I would say we need to learn, disseminate the idea by example, just giving good teaching cases on the importance of briefing and exercising in everything we do, even research, clinical work, management, because it's so useful.
Be really powerful and really helpful to make sure that the same things don't happen again and to protect staff.
The thing is that everyone is using it. There might be a reason. Of course, that whatever the world does is not always correct, but every high-risk industry is using the same tools.
Thank you very much.
Thank you.
We're just coming to the end of the time, so we're going to pass back over to John, who's going to take us through a few pieces. One thing just to mention, Just Culture came up a lot today. And the 23rd of May, there is a Just Culture conference on within the HSE, and that will be advertised shortly. But in the meantime, pop it into your diaries, 23rd of May, an important date. So John, we'll pass back over to you.
Okay, folks, well, it's been a real pleasure to have you here with us today, and I hope that you have been able to benefit from hearing some of the speakers at the workshop today, and we're really grateful to them for giving up their time and their lunch break to come and join us. Our next event, which is next Tuesday, I think, isn't it? On the 4th of April, we have Dr. Murish Houston, who is going to talk with us about narrative medicine. And I think that'll be a really interesting discussion, I think, about narrative medicine in itself, but also how we can use it in improvement and in patient safety, and how I think we can use it also to benefit staff working in the healthcare system. So yeah, just let people know about the prospectus, and please to use the QR code there and explore the prospectus to see what's available. And please do get in touch with us if you have any questions about that. And again, Orla mentioned the Patient Safety Together platform, so do check that out. And there's lots of things there: patient safety alerts, supplements, which are kind of bringing up common challenges in patient safety and lessons that should be shared. So do check in, and that will be a website that's continuously changing. Patient safety stories will be continuously added. And again, I think as we've been talking with Jeffrey and hearing here today, the importance of networks and knowing who's out there and connecting people doing this work. So please get on the map, or advise somebody if you're already on the map, advise somebody else to get on the map or help them to do it. And we can join everybody up. And then Q Community is the other network really we'd like to see people join up, not only across Ireland, but also across Northern Ireland and the UK. And there we are on Twitter. And if you didn't manage to watch the whole of our meeting today and the interviews with our guests, you can see the video on YouTube, hopefully in the next few days. And please do engage with us on Twitter. And thank you very much. Again, you'll get a brief survey. Please do give us your feedback. It's nice to be doing these events where we can get out and meet people at workshops like this. So let us know what you think of that. And I look forward to seeing you all on Tuesday.